Good evening, everyone. I'm Diane Stevens, Chief Executive of TOFS, and a really warm welcome to the first of our Q&A sessions for 2025. Tonight, over the next hour, we'll be talking about long-term OA-TOF related gastro issues. And we're really delighted to be joined by Professor Nick Maynard, a name that I'm sure many of you will recognise. Professor Maynard is a leading consultant upper GI surgeon with a real interest in OA-TOF repair as neonates. He's been with Oxford University Hospital since 1997, and many of you might recall that he has generously given his time in the past to either speak at TOF conferences or to take part in webinars like this one. It's been 3 years, Mr. Maynard, since you last joined us, so lovely to have you back, and thank you for being here. We'll also be joined during the session by TOFS trustee Kate Tyler, who heads up our adult TOF working group and is herself an adult born with OA-TOF. So we've got quite a list of pre-submitted questions from members, which we'll crack on with very soon. And the event is being recorded, so technology permitting, you'll be able to catch up and see the recording of this in a little while once we upload it to our YouTube channel. There might be an opportunity to post questions at the end, and you can do that using the Q&A function at the bottom of the screen. But it's time dependent because we have about 20 questions to get through, and we tend to prioritise the questions that have already been submitted. So if you're ready, Nick, I will carry on with the first section of questions where people have been asking primarily about reflux and endoscopies. And the first one comes from a parent of her daughter is 18-year-old, and she was born with short gap OA-TOF. She didn't seem to suffer from reflux as a child, but in the past year or so, she's been constantly spitting up yellow phlegm and sometimes chokes on her saliva at night, which sounds really unpleasant. They have seen an upper GI doctor. She has had a scope and a barium swallow, and the doctor said there wasn't any evidence of reflux and that her motility is fine, and she's subsequently been discharged. So where might you suggest they go from here?
Okay, well, again, thank you for the introduction, Diana. Thank you for inviting me again. It's always a great pleasure to join TOFs either in this forum or at the meetings. Yeah, so endoscopy, I mean, the investigations of an endoscopy and barium swallow are very sensible investigations to have, and that will be very reassuring that they haven't shown anything to worry about particularly, but they can't exclude reflux, and they can't exclude a motility problem, because more tests are sometimes needed to be absolutely sure about the presence or absence of reflux and how the motility is. And certainly in my experience, virtually everyone who's had a esophageal atresia repaired has some degree of dysmotility, and even though it's clearly reassuring that barium swallow, I imagine, allowed everything to go down well, it doesn't mean there's not dysmotility. But I guess the other question is whether or not the spitting up yellow phlegm and choking on saliva is indicative of reflux or not. And again, those symptoms can be due to reflux and can be due to esophageal motility problems, but they're not necessarily due to that. Some TOF patients do have a degree of respiratory problems. Sometimes they can get sometimes weak airways and sometimes recurrent chest infections. And coughing up yellow phlegm, it's not clear to me from the question whether that's just maybe mildly infected phlegm, which could simply be related to an airway problem or even a sinus problem or something like that. And choking on her saliva, again, I'd want to explore that a bit more by talking to the patient, and is it really choking on the saliva, or is it reflux coming up and spilling over? So it's a little bit difficult to know exactly where to go with that, but and I think probably the important thing is to see someone who really is used to seeing. This is going to be a recurrent answer to many questions, is seeing someone who's used to seeing adults who've had TOF repairs and OA repairs, because they tend to look at the whole picture and think about all the different possible reasons behind it. But with that limited information, it's not entirely clear to me what the problem would be. But certainly, simply having had an endoscopy or barium swallow, I think that's an excellent place to start. But it doesn't mean there isn't a problem with reflux and dysmotility. And perhaps the next step would be to try and talk to someone, you know, who has a real interest in these areas and may well be able to have a slightly more nuanced approach to it and think about further tests.
Thank you. That's helpful. I think that we should perhaps jump forward then just to a couple of questions further along, where someone has asked how to access support with gastro problems when they feel they're always fobbed off with either GERD or gastroesophageal reflux disease or IBS, irritable bowel syndrome, as an answer, and clearly they suspect that it isn't.
Yeah, again, I mean, it's probably to a degree what I said earlier, and this is, I think, is really, really important. This is such a familiar thing I hear from patients, and I'm sure Diane and you and your colleagues hear this at TOFS the whole time.
Absolutely.
I mean, the brutal truth is that a lot of people, unless they've got a particular interest in patients who've had a TOF and OA repair, don't really appreciate the difficulties and the functional problems people have with the esophagus and the stomach as well sometimes, and of course the airways. So I think what you need to do is find someone who has an interest and can talk about these problems in more detail and investigate appropriately. There aren't that many people, but what we are doing, and again, we've talked with TOFS about this, what I'm doing with some of my colleagues who specialize in the same area as me, and there's a handful of us around the country who are really interested in these problems, and discussing with the pediatric surgeons, talking about getting regional referral centres where you can almost, wherever you are in the country, you'll be able to see someone who's got a particular interest and will be able to address these sort of problems. So we've probably been a bit slower than we planned in setting that all up. We've made a start, but we are going to follow that all up. One thing I should add, Diane, if there's not time for patients who pose these questions to come back to me, if you want to pass on further questions I can address by email, I'm more than happy to do so.
Thank you. And that's really encouraging to hear that news as well. So thank you very much, Mr. Maynard, in relation to the regional referral centres. Moving on then to the next question. Why is it so hard for those born with OA TOF to get rid of the phlegm when having a cold? And the same person has asked, is acid reflux always going to be a problem?
So I mean, again, if it's phlegm related to a cold but not related to reflux, again, I'm not entirely sure from the question, is it because you're getting a lot of reflux and that's exacerbating the problems with the phlegm? But I guess if you get a cold and you have a lot of phlegm, there are two main reasons why that might be a problem. Either because your trachea is weak, and that is known to be a problem in people in people who've had a TOF repair, and sometimes, not commonly, thankfully, but occasionally the trachea can be incredibly weak, and it can be very, very difficult to expel, to cough up phlegm, and that can lead to recurrent infections. The other problem is that if you have got reflux, and indeed you may not know you got reflux, you may have what's called silent reflux, that can, of course, lead to a big increase in phlegm. So again, I think that there may well be good reasons for why you're having this problem, but we'd need to explore it a little bit more with someone who's got an interest in this area. And the final thing to say is, you may have sinus problems or postnasal drip unrelated to your TOF and OA, which could exacerbate all those things.
That's interesting. Thank you. Our next question is from someone who says that they only ever eat small meals. However, they quite often feel sick and feel like food is stuck in their throat whilst they're eating. The stomach gets quite bloated And if they put their hand where the diaphragm stomach is, it feels quite hard. And they're curious to know if this might have a link to OA TOF or if it could be something else entirely.
Well, it could very much be related to that. And I guess what's going through mind is that if you're feeling food is stuck in your throat, that may well be related to your esophageal problems, either because where the repair took place, there might be a slight narrowing there, a stricture. And many of you I know will have had dilatations over the years. One thing that is really worth pointing out, and perhaps people who don't see a lot of OA patients don't appreciate, is that because patients who've had an OA repair have very significant motility problems as well, what might appear down the endoscope to be a very, very mild stricture at the joint can actually cause far more problems because of the associated motility problems than it otherwise would. And what that means is that if you have an endoscopy by someone who perhaps doesn't see a lot of OA patients, they might see a very, very mild stricture. They'll say, well, that's not a problem. That wouldn't normally cause problems. So it doesn't need dilating. But because you've got the dysmotility as well, actually a dilatation really can often help that. And I see a lot of people who I do a dilatation, it can make a difference. So I think your esophageal problems with food sticking in your esophagus could represent, there might still be a very mild stricture, which might benefit from a stretch. And it might represent the fact that the esophagus has very poor motility and won't empty properly. So when you swallow food, it hangs around in the esophagus much longer than normal. With regards to your stomach getting bloated, sometimes in patients with who've had OA and repair, because the vagus nerves are not always functioning particularly well afterwards, sometimes there are problems with the stomach emptying. And there's a condition called gastroparesis, where the stomach is effectively partly paralyzed. And that can be quite slow to empty. And that can cause a sensation of getting full up very, very quickly, only able to tolerate small amounts of food and getting very, very bloated. So what you're describing absolutely could be connected with the OA, and I think you'd need to have further investigations if you haven't had an endoscopy and a barium swallow, and there's a specific test called a gastric emptying study, which can assess how well the stomach empties. So I think, yes, it could be connected, but you need to have some further tests to look into it.
Thank you. Question 5. Where no symptoms other than reflux are present, how often should an upper endoscopic biopsy be performed once my child turns 18?
So
Your
it's a very
opinion.
good question, this, and there's no clear answer. I mean, I'll give you my opinion, which I guess is what you want, but there are no strict guidelines. If you've got reflux, I mean, what everyone I know is concerned about is the development of Barrett's and the development of esophageal cancer. It is actually incredibly rare. There are a few case reports in patients who've had OA, but it is still in the grand scheme of things, it's still a very, very low risk. Having said all that, you are patients who are likely to be getting reflux all the time or at more risk of getting reflux. And I would certainly recommend someone has an endoscopy at some stage after 18. And then if it's normal insofar as there's no Barrett's, then probably I would argue have one every 5 years or so. If you have got Barrett's, then you'll go into a regular surveillance program, which is usually every 3 years. Now, if there's no Barrett's, you might, I'm afraid, have difficulty persuading your local gastroenterology team to do an endoscopy, but I tend to advise an endoscopy every 5 years or so, that sort of frequency.
Thank you. Question 6 comes in from a parent who writes us from Northern Ireland and tells us that her son has been assigned to an NHS adult gastroenterologist consultant. During pediatric care, all of his scopes and dilatations were done under general anaesthetic, but the consultant in adult care wants to do future investigations under sedation and thinks that her son will tolerate it, and her son has a severe phobia due to previous trauma. And the parents asking how she goes about addressing that with the consultant.
Yeah, I have a lot of sympathy for that, and it's something we not uncommonly see at this sort of age when everyone's been used to having them under general anaesthetic for all the obvious reasons. I mean, in adults, 99% plus, even more than that, of endoscopies are done under sedation. But that can still be quite heavy sedation, and to the extent that although they're not fully anaesthetized, they're minimally aware, and even if they're mildly aware, they're very, very sleepy, very relaxed, and would be very good at controlling any anxiety. Now, there are some patients who do need a GA for an endoscopy, and I have got a few who've needed that. But in my experience, I really sympathise with these concerns. But in my experience, the vast majority, it clearly requires a lot of a sympathetic approach and a sort of a gradual increase in sedation, and not starting until the patient is nice and relaxed and very, very sleepy. But it's nearly always doable. So I don't know how sympathetic your consultant was, and maybe they could have been a bit more sympathetic, but I think a combination of a very sympathetic endoscopist and very gentle increase in sedation is nearly always, in the vast majority, sufficient. And maybe reassure your son that it is always very possible doing it under that, and hopefully he can be reassured by that. I don't know if that helps or not, but
well, I think at the end of the day, I guess the parent can get in touch with us again, but it sounds helpful to know that they can ask for an increase in sedation that might make it a little bit easier for us.
Yeah, there's people. We always start off with a very small amount of sedation, and sometimes it's called conscious sedation. So people are awake, but just relax. And some people tolerate incredibly well. Some people do need more sedation. I've got some patients who need a vast amount of sedation, but you can see there are different levels of sedation you can give. And what we tend to do is give a little bit, wait, see how they are, wait until we get the balance right. And you can't always predict how much they need, but gradually increase it until the patient is really, really relaxed, may well be very sleepy, and then they tolerate it much more easy than you might think.
Thank you. Moving on now to a slightly different topic, medications. And the first question we have under that are, what are the long-term impacts of lung gap esophageal atresia, and are there any helpful medications?
Well, I guess the long gap, I'm presuming that means that they've had either a very long stomach pull-up or perhaps colonic interposition. I don't know. So the long-term impacts of it's really the reconstruction that causes the long-term impacts. So delayed transit, delayed passage of food through the reconstruction can be a problem. It's not always a problem, but it can be a problem. If it's just the stomach being used to pull up, which is unusual for long gap, but occasionally can be used, then clearly that may lead to a lot of reflux problems. So if there's reflux, which is a problem, then drugs like omeprazole or other proton pump inhibitors can help. But if it's the more predominant problem is sort of motility problems and symptoms which may feel like reflux, but actually they're sort of reflux within the conduit. So it's not due to acid, it's due to food coming back up. And they are difficult problems to deal with. There are some drugs which can help try and increase the motility of the conduit. There's something called azithromycin, prokinetic agents. they're not brilliant, but sometimes they're worth trying. So I guess most of the impacts are related to either poor motility or reflux.
Thank you. I'm moving very quickly through these because we have quite a lot to get through. But the second question in this section relates to a parent who tells us about her daughter had a stomach pull-up and she never had any problems with reflux. However, she's recently been given 10 milligrams of omeprazole. Does she need it?
Well, not really if she hasn't got reflux, but it'd be interesting to know why the GP started it. Maybe the GP thought she did have reflux, and even if she hasn't got the very typical symptoms of reflux like heartburn and acid taste and food coming up, maybe she's getting a lot of chest infections, which the GP thinks might be due to reflux. So it's probably worth talking to the GP why. But if genuinely she's got no reflux at all and there are no symptoms suggestive of reflux or chest problems related to acid, then there is no need to be on omeprazole long term as a sort of protective thing.
Yeah, so back to the GP really to have another conversation. Yeah. And that takes us on nicely onto the next question, which is asking what the risks are of esomeprazole and is it safe to stay on anti-reflux medication?
Yeah, it's a really good question. It's one we get asked a lot. I mean, every single long-term medication will have some side effects and risks. And the sort of risks you can get with esomeprazole, and I'll mention the proven risks, and I'll address perhaps some of the risks that get attention in the media, which are not really founded. So it is very well established that long-term use of esomeprazole or omeprazole or all those drugs can and all these things are rare, I promise you. They can rarely cause problems with magnesium levels in the blood, and they can rarely cause problems with the kidneys, a rare type of nephritis. Now, I think I've seen each of those once in over 30 years of practicing. So they are vanishingly rare, but they do occur. But they're very, very rare. In females who have gone through the menopause, these drugs can cause osteoporosis. So people who have osteoporosis, one would be concerned about having these drugs long term. But for young people, that's not a concern at all. Those are all well established but rare risks. There's stuff you read in the media and online about cancer risks. There are no cancer risks with these drugs, so that can be dismissed. There are some risks with there's some evidence of increase the risk of some gut infections. The main one that's the risk exists is of getting an infection called Clostridium difficile, which you may have heard, or C. diff infection. It's only really been established as a risk if they're in hospital already. So for most of you in the community, it's not really a relevant risk. There's been stuff in the media about increased risk of dementia, but that link is really very, very weak indeed. So not really proven. So of course there are some risks with these drugs, but they're very, very low. And when you talk about any drug or any operation or anything really in procedure, it's always important to weigh up the risks and the benefits. And there's you don't want to be on a long-term drug if you don't need to be on it. But if the alternative is having terrible reflux symptoms, then the benefits clearly outweigh the risks. So it's absolutely right to question whether you need to be on a drug. But if you're getting very clear benefit from it, then almost certainly it's the right thing to be on, because the risks, although they're there, they're very low.
That's helpful. Thank you. Moving on to the last question in this section then, a member asks, from OGD, I have gastric polyps, which are a common feature after long-term omeprazole. Can you talk about this?
Yes, of course. They're very common. They're not, strictly speaking, they're not polyps, although they're often called polyps. They're what are called fundic gland cysts. And they are basically cysts within the glands in the top of the stomach. and they're minute little collections of fluid. They are of no consequence at all. They are insignificant. They don't have any risks associated, and they can't become cancerous at all, and they can be ignored.
Okay. Well, that certainly sounds very reassuring. And just the start of that question from OGD, is that from doing scopes, from having
Yeah, OGD is
endoscopies?
they're seen at endoscopy, and they're often commented on, but they have a very characteristic appearance. And as I say now, I mean, I would never biopsy them now. They often are biopsied because people don't know what they are. But once you've seen a few, you've seen them all really, and they're very characteristic appearance, and there's no risk with them at all.
Okay.
But if you're told you've got polyps, do ask to make sure they are what I'm describing. They're the common ones you get with these drugs.
Okay.
I mean, the second part of that question, intestinal problems with polyps, that's no connection to this whatsoever. That's something completely different.
Okay. And that's a question submitted by someone who's told us that their son is having a few intestinal problems, i.e. partial blockage with a polyp. Is there any links? And you're saying absolutely not.
No.
Nothing to do with the weight loss. Okay, well that's
there are some polyps which you can get in the stomach which are linked to polyps in the colon, but they're not the polyps that we're talking about, which are related to omeprazole and drugs like that. There's no link between them.
Okay, well, thank you very much. I'm going to pass you over now to Kate and welcome Kate onto the call. Kate Tyler is one of our trustees. She's an adult born with a weight TOF, and she leads our adult TOF working group. And Kate, you're going to go on to an entirely different subject, aren't you?
I am
with some
indeed,
questions.
yes.
Thank you.
Good evening, Mr. Maynard. Thank you for inviting me, Diane. Hi. I am completely different subject, really, around palpitations. Something that I've experienced many times over the years, and I thought was related to going through the menopause, but I'm way past that now and continue to have these episodes. But interestingly, because I'm involved with quite a lot of adult TOFs, and this subject comes up quite frequently. So my questions really are, can they be related to our congenital malformation? Is that possible that the vagus nerve has not developed correctly, much as the trachea and the esophagus did not in the embryonic stage? I've had all of the whole range of cardiac investigations, the 24-hour ECG and the echo and exercise tolerance, and I've just been told there's nothing abnormal, that avoid caffeine and try and reduce any stress. So I'm very reassured in that respect. But when they happen, and I've heard this with other adults, they're really quite unsettling, and you can feel quite tired and have a mild headache afterwards. So there's three questions. Is it possible that it's related to the vagus nerve? Why have they come on much later in life than they weren't happening when I was much younger? And any ideas how we can just get through those episodes, really?
So I think it's very unlikely to be related to the vagus nerve. I mean, I'm not a cardiologist, clearly, but I don't think it's likely to be related to the vagus nerve at all. The vagus nerve often can be malformed, clearly, in patients with LOA, but it's usually sort of below the level where the branches go off to the heart and to the airways. So it's more likely to be abdominal problems related to vagal nerve weaknesses, and I don't think it's going to be related. Will cause palpitations. And I think if it were related to the vagus nerve, it would have happened much earlier than in your 40s. So, I mean, could it be related to your OA repair? Yes, it's possible. And the way I've had some patients in whom it's been related is if the esophagus is quite immotile or dysmotile with poor motility, the esophagus can dilate a little bit, sort of get a bit wider. And food, as we've heard already, and many of your experience, will be slow to get through the esophagus possibly because of a stricture, or more likely because of the dysmotility. So if food is very sluggish to go through the esophagus, it can cause the esophagus to swell a little bit. The esophagus is in direct contact with the heart. And if the esophagus swells, it can press on the heart. Now, I'm not saying that's the cause with everyone with their palpitations, but I have had a handful of patients in whom that is a very, very clear possibility. And I guess one thing that might suggest that's likely is if the palpitations are related to eating. If the palpitations are worse when you eat or soon after you eat, that might suggest that's a possibility. So I think if there's a very clear association between eating and palpitations, it might be worth, and again, a barium swallow might help investigate that. It might be helpful talking to a cardiologist about that, or talking to someone like me who's got a particular interest in this area. And if that were the case, there's a lot of ifs and buts here because we don't know. But if that were related to that, then anything to increase the speed with which the esophagus empties would help, or perhaps simply slowing down the rate of eating and the volume of eating and everything like that. So dietary changes might help if that were related. But I mean, palpitations are very common and these sort of problems are very rare. So it statistically is unlikely to be the cause, but that's one way that an OA problem can lead to palpitations.
Okay, thank you. Okay. Do you think it could be related to reflux at all? Because I know when my reflux has been not say out of control, but not very well controlled, I've experienced these sort of hot flushes and then palpitations. But you think that's just coincidental?
No, I mean, I guess if you're having really bad reflux, then it might, it'll sort of, you'll feel stressed. Your sympathetic system, nervous system will be heightened, and that can all, and so you'll have more adrenaline, and that can all lead to palpitations. Certainly, if you're prone to getting palpitations anyway, anything that causes you stress will exacerbate that.
Yeah. All right. Thank you. Thank you very much.
Thanks, Kate, for coming on to ask those as well. Mr. Maynard, we're going to a different area now, lungs and airways, which might not so obviously fall into your area of interest, but I have 3 questions here. The first one is from an adult who was born with a weight of in 1990. For the past 5 years, they have suffered a lot with bronchiectasis, if I've pronounced that correctly, which is getting worse. She's experiencing more acid reflux now, and she's asking if there's anything she can do to prevent the bronchiectasis from recurring.
Yeah, that's a good question. And I do see a lot of patients like this because I have a brilliant set of a respiratory consultant and a thoracic airway surgical consultant with whom we work together on some of these patients. So there are 2 reasons why why patients who've had OA and TOF repair might be getting bronchiectasis and recurrent chest infections. Firstly, reflux, and that is absolutely the commonest cause by far. And if the reflux, and it should be pretty obvious to your respiratory consultant whether reflux is causing this. So you need to ask whether, if reflux is thought to be the cause of this, then you can absolutely prevent the bronchiectasis getting worse by getting control of the reflux. And that is either by taking proper medication like omeprazole, and that's very, very good at controlling acid. Or occasionally we do operate and do something called a fundoplication on patients who've got bad reflux associated with OA. So there are laparoscopic operations we can do to prevent reflux. It's worth bearing in mind that some patients do get what is called intraesophageal reflux. So that when we talk about reflux, we talk about gastroesophageal reflux, and that means reflux from the stomach up into the esophagus of acid and sometimes bile. And that's because the sphincter at the bottom of the esophagus doesn't work very well. And that's very common in people who've had OA repair. Occasionally, food that is very sluggish to go down the esophagus and stays in the esophagus because it's the motility say bad, can then reflux back up within the esophagus. and that's called intraesophageal reflux, and that can cause all the same symptoms of reflux. And of course, if that comes up and goes into the lungs, that can cause bronchiectasis. So it's worth your gastroenterologist or interested esophageal surgeon or whatever, it's very important they consider that if you have got reflux, just to be sure it's gastroesophageal reflux rather than intraesophageal reflux. It's quite a difficult concept sometimes for people to get their heads around, but I'd be more happy to talk about that further afterwards or in an email if necessary. But I think many people who see the occasional patient like this will not think of intraesophageal reflux, and that's esophageal contents stagnating in the esophagus and refluxing up within the esophagus. That can be a problem. It's not common, but it can be. The other reason why bronchiectasis may be a problem in these patients is if they've got tracheomalacia or what's called dynamic airway collapse, which is slightly different to that. And that will lead to a lot of secretions going into the lungs and causing recurrent infection. So that can be a problem as well. So again, your respiratory doctor absolutely should be able to reassure you, hopefully, that there's no inherent airways problem and whether or not reflux is causing this.
That's interesting. Thank you. The second question in this section is from someone who believes that her most prominent issue is with tracheomalacia. Every time she goes to sleep, relaxes, her trachea goes floppy or collapses, which then causes her to cough. And when she coughs, the food and drink comes straight back up, no matter how long it is since she's ate or drank. And you perhaps covered that a little bit already. I then often aspirate on this reflux. This is a 40-year-old female with chronic lung problems due to the ongoing aspiration and her bronchiectasis. Her question is there such a thing as a trachea stent or trachea surgery, or what are your thoughts on a tracheobronchoplasty, the good and the bad side of
Okay,
things?
great questions. So yes, I've got quite a bit of experience of this with my respiratory colleagues. So I'm not a respiratory doctor. I'm not an airway specialist, although I've seen a lot of patients with these problems, and I work closely with my colleagues. And absolutely, there are some patients who've had a TOF who have real problems with their airway collapse. And the respiratory specialist will be able to advise best on how to manage that. I don't know whether they talked to you about some patients have mask CPAP, continuous positive pressure breathing at night, which keeps a continuing. So when we normally breathe, the reason why people with tracheomalacia get obstructed airway is that when you take a deep breath, the pressure inside your chest and therefore inside your airways becomes very negative, which is why air rushes in. But and the reason why our tracheas have cartilage rings in it is to prevent it collapsing. So what tracheomalacia is, or what this condition called dynamic airways collapse is, and it's associated with a TOF, is when there's some cartilage missing. So you typically, on the back wall of the trachea, you have an absence of cartilage. So that membrane, when you take a breath in, the pressure inside your chest becomes negative. So that membranous part without the cartilage gets sucked in, and it blocks off the airway, and it can be terribly, terribly frightening for patients. So just putting on a mask when you're at night sleeping, and that's used quite often for people who have airway problems, it keeps the pressure positive and it prevents it collapsing. So that's called CPAP, CPAP, and it might be worth talking. Occasionally that can be helpful in this situation. The trouble with CPAP is it worsens reflux, I should add. So it's a catch-22. And I've had patients who've tried it and it hasn't worked. There are tracheal stents. Yes, we do use those. They're very, very rarely a long-term solution. And we have used them only as a temporizing procedure prior to more major tracheal reconstruction. And that brings me on to tracheobronchoplasty. We've had a couple of patients we've done this on. it's basically you reinforce the trachea by putting some effectively scaffolding around the trachea, and it's like a semi-rigid mesh which goes around the back of the trachea and stops it collapsing. I mean, that is very, very major surgery. To my knowledge, there's only one surgeon in the country who does it, and he came down to us to help my thoracic surgeons do it, and we had to do it. We combined it. The esophagus had to be removed as well for various reasons. So that was very, very major surgery indeed, and very, very rarely necessary. But there are, I guess the answer is there are surgical procedures which can be done if the tracheomalacia is a really, really big problem. So, I mean, I know for a fact that we are the only centre who's done this sort of combined tracheal reconstruction and esophageal reconstruction. So it's incredibly specialist stuff. So I think the answer to this, to the questioner, is to maybe talk to the respiratory consultant. The reflux makes things much, much worse, and that really need this condition, this situation needs to be discussed really by experts who really do have a specialist interest in this area.
Well, thank you, and thank you for explaining that so clearly as well. The final question in this section is from an adult who has been breathless all through life, but the last 3 or 4 years it's got worse. And they've had lots of tests and inhalers which haven't helped in the slightest. If anything, they feel it's made the problem worse. On a scan, they found I had a right paravertebral subpleural soft tissue. And they don't know if this has anything to do with the situation getting worse or not. Do you have any suggestions?
Yeah, I mean, I doubt that's significant at all. I mean, it sounds like, I mean, I'm assuming this is probably some scar tissue involving the pleura, and it's quite common. It's very, very unlikely to be related to your breathing problems, unless it was very, very extensive. But it doesn't. If they've said it's right paravertebral, then I think it's very unlikely to be related to this. It might indicate some underlying problem with the lung, like a recurrent infection or something like bronchiectasis. But again, if you've had scans, they would have ruled that out. So I'm not a respiratory doctor, so I'm not sure I can really work out what's causing the breathing problems, but it might be worth talking to your respiratory doctor and just being sure that they've ruled out any problems with your airways, and that, the tracheomalacia or dynamic airway collapse, and ruling out any problems with reflux, because those are the two problems which really can cause breathing problems in people who have had OA and TOFs. So it's worth just ask them outright. Could this be due to silent reflux? Could it be due to airway collapse in any way? Because both of those can be significant issues, obviously, with TOF and OA patients.
Thank you, that's helpful. We have one final question now on dumping syndrome, and then a couple of general questions, and then we may have time to look at the Q&A section and take some questions from members here tonight as well. So the dumping syndrome question: do OA TOFs who have had a colon interposition in childhood, are they more likely to get a diagnosis of dumping syndrome? And would the surgery, that is the colon interposition, have moved the position of her stomach in any way? And is that why it empties more quickly?
Sorry, that's it. So it wouldn't be usual to get a lot of dumping with that, but I mean, the bottom line is anyone who've had any stomach surgery at all can get dumping problems. So I think there will you don't commonly see it with esophageal reconstruction with colon, but it's possible, certainly. And I mean, the characteristics of the dumping, they're very clear characteristics of dumping syndrome. And I think if it's been suggested as a diagnosis, it may well be the right diagnosis. Seeing a dietitian with a particular interest in stomach problems would be a really sensible thing to do, because they're really good at not only diagnosing dumping, but also advising how best to manage it. So that might be a good starting point. I mean, one of the ways why dumping can be a problem rarely in people who've had a colonic interposition or other reconstructions is that you're absolutely right. It's related to rapid emptying of the stomach, but that doesn't necessarily mean the stomach empties quickly all the time. And if there's something causing a mechanical holdup, for example, a colonic conduit or a stomach that doesn't empty very well, things build up. And then suddenly, when the pressure in that conduit gets high enough with all the food, it suddenly empties and things pour through, and that can then cause dumping. So it's quite a difficult concept. I'm probably not explaining it very well, and I'm sorry about that. But sometimes if you've got mechanical problems slowing things down, that leads to things suddenly in a rush getting through when the pressure gets up, and that can cause dumping. So paradoxically, sometimes speeding the way things go through the conduit can reduce the dumping problems, if you see what I mean. So I guess it's important to talk to. I'd try and get access to a dietitian, but not a general dietitian, a dietitian who's got a particular interest in esophagogastric problems, and just, maybe get to see someone who's interested in this area, like me, or someone like me in another centre, who can look at the totality of your anatomy, really, and see whether there's a mechanical problem going on as well.
Okay, thank you.
You've asked whether it moves the stomach. I mean, it doesn't move the stomach, but I mean, you do operate on the stomach because you have to stitch the colon onto the top of the stomach. So it does interfere a bit with the stomach, but it shouldn't move the position of the stomach anywhere.
Okay, thank you. The second question, Mr. Maynard, what is the typical size of a healthy adult's esophagus? This is interesting. And how small would the OA stricture have to be to need a stretch?
Okay, great question. And I sort of vaguely alluded to this earlier. So the normal esophagus is, it varies in size, but it's between 1.5 and 2 centimeters, maybe 15 to 18 millimeters. But obviously, it's very, very distensible. So it gets much bigger when you swallow big lumps of food and things like that. But the normal esophagus would be maybe 15 millimeters, maybe up to 18 millimeters. But the esophagus in someone who's had a OA repair is usually bigger than that, because if an esophagus has poor motility, it almost invariably stretches and becomes wider than that. So then, I wouldn't know what the average diameter is in a TOF, but I'd say it's probably 2 centimeters, maybe 2 centimeters. But it is generally bigger. And the question about how small would an OA stricture have to be to need a stretch is a brilliant question, because this is something I don't think many people who do endoscopies really appreciate if they don't see a lot of TOF patients. So, and I'll repeat what I said earlier. So normally, if you've got a completely normally functioning esophagus and you've got a stricture, we would normally dilate that stricture up to a maximum of 18 millimeters, because that's all you need. But actually, even if the stricture is down to 12, 13 millimeters, you can normally pretty well, but just be careful. But it's very different with a TOF patient. So because a TOF patient has got very poor motility, the effect of the poor motility massively magnifies the effect of the stricture. So what that means is that a very mild stricture can cause far more problems in an OA patient than it would do in a normal patient. So if you look down and the stricture looks very, very mild, then most people would have to say, oh, that's nothing. Or some people get this, you might have heard this, some people describe it as a bit of a shelf where the reconstruction is. And they say, oh, that's a bit of a shelf. But the esophagus is wide open, the scope goes past easily, it's not a problem at all. But it is a problem in people with OA repairs because the motility is so poor that a little bit of hold-up makes much more of an impact. So in answer to that question, I would have no hesitation in dilating a stricture that was very mild, that might even be only 18 millimeters, and I'd stretch that up to 20 millimeters, and that can make a big difference. And I've had many, many patients over the years who've had very, very mild strictures which have been ignored, and then we dilate them, and it makes a big difference to their swallowing.
Well, thank you. And the final question, it relates to, are there any complementary therapies or lifestyle changes that have been shown to improve symptoms of overall well-being?
So I'm probably not a brilliant person to talk about complementary therapies. My wife would be much better than me at that, because she's. But I mean, I think anything that leads to the sort of symptoms that patients with OA and TOF get, many of them can be exacerbated by anxiety and stress and things like that. So anything that reduces all of that will be very, very good for you. Dietary factors are incredibly important. I think what you eat, how you eat, can have a huge impact on symptoms from your esophagus in people who've had OA and TOF. So looking at eating healthy foods, reduced carbohydrate is nearly always better in people with esophagogastric problems, because it reduces the risk of dumping and everything. So reduce carbohydrate, increase the amount of protein. And obviously, if you're overweight, that's very important to address as well, because being overweight will worsen all the problems you might get from OA and TOF. So to summarize, I think healthy diet, reduce the amount of carbohydrate is generally a very good rule. Make sure you're of a good weight. I mean, clearly smoking and drinking I'm not talking about, if you're an adult, the very occasional drink's fine, but excessive drinking and any smoking will be bad for these sort of symptoms. And generally try and lead it's easier said than done, a stress-free, anxiety-free lifestyle.
Okay, well, thank you very much, Mr. Maynard. I'm sure everyone found that useful. We have 8 questions in the chat, so if you're happy, I'll go ahead and ask you some of those.
I'm very happy.
Yeah, we might have to be fairly brief, ask you to be brief in your responses if at all possible. So I'll just go through them in the order they've come. The first one are, what are the chances of TOF causing other issues, or is it the OA TOF caused by other issues, e.g. caused by other developmental issues or comorbidities and feed into each other, for example, Ehlers-Danlos?
I don't know the answer to that, I'm afraid. It's a good question, but the pediatric surgeons you have on your medical advisor would be much better placed at answering that.
Okay.
And the OA and TOF, it shouldn't lead to other problems. It can lead to lung problems. We've talked about bronchiectasis. It can lead to digestive problems, what we've talked about, but it shouldn't lead to problems elsewhere in the body.
That's fine, thank you. And what is the best way to manage gastroparesis? Apologies for my pronunciation of that.
It's difficult, so we have a very structured program for treating it. I mean, dietary changes can help. We go through a couple of drugs which can help, which can strengthen the contractions of the stomach. And if these don't work, we can put balloons into the pylorus, which is the sphincter at the bottom of the stomach, to stretch that. We can inject it with Botox as well to improve the emptying. And very, very occasionally we do surgery on it as well. So there's a graduated program: drugs, endoscopic treatment, surgical treatment.
Sure. Okay, thank you. Is a gastric pacemaker going to be any help to people with OA TOF or symptoms related to this? Oh, sorry, that's the one that we've just done.
Well, no, but I didn't mention pacemaker, so it reminded me to say there are a couple of centres around the country who do put in pacemakers for gastroparesis. It's a bit hit and miss whether it works or not. There's no really good science behind it, but I've had 1 or 2 patients whose lives have been transformed by a gastric pacemaker with gastroparesis. So it can work, which is not very good at predicting when it's going to work. Okay.
Well, hopefully that's helpful for you, Felicity. Tara's asking, it would be great to hear more about treatments for intraesophageal reflux, as you mentioned earlier, if there's time.
Yeah, so very simply, if there's intraesophageal reflux, the first question is there a mechanical problem? Is there a narrowing? Is there a stricture which you can open up? So the 2 reasons why there'd be delayed transit through the esophagus is either because there's a mechanical problem like a blockage and narrowing, which you need to open up either by dilating it or occasionally with surgery, or if the paralysis or motility is so poor. That's very difficult to deal with. But basically, in order to improve intraesophageal reflux, you need to try and increase the speed with which it goes through into the stomach. But there's no drugs you can treat it with. It's usually trying to improve things mechanically.
Yeah. Okay, thank you. This is a question pediatric, and again, we can put this to Mag, but I guess the same applies to adults. Our 4-year-old son with OA-TOF has a really poor appetite and eats very little. So I guess that can happen in adults as well. Is this normal? Any suggestions to improve things?
Yeah, I mean, it wouldn't be particularly normal in adults. I mean, I'm not a pediatrician clearly, but I mean, I do know that children who have difficulty with eating will often just declare they don't want to eat by not hungry, that sort of thing. So it may simply reflect the fact they've got some difficulties with eating. So it's important to go and talk to the pediatrician. Could there be a stricture that needs dilating, for example? You know, if the food gets stuck, they may just not want to eat. So it'd be worth talking about that. But my experience in adults is that, I mean, clearly if they've got real difficulties eating or they've got gastroparesis can very much lead to reduced appetite. So there may be some problems which need investigating leading to that.
So go back to the hospital and talk to
I would absolutely,
with their son's care. Okay, thank you. Gaynor tells us that her son is in Australia, is drinking more alcohol than usual. Can this affect his esophagus? Also, he's just had a partial blockage of the intestine. He had a polyp, and you said it's not linked. Another interesting fact is that he's no breathing problems or needed his puffer since leaving the UK.
All right. So, I mean, yes, alcohol can worsen problems in excess because it can make reflux much worse. So I guess there's a very strong link between alcohol and reflux because alcohol will weaken the lower esophageal sphincter even further. So yes, excessive alcohol can worsen reflux.
Okay, thank you. This is from a patient of yours, Mr. Maynard, who was told she was asthmatic as a teenager, but recently told by a cardiologist that she didn't have asthma. They found on the CT scan that she had a small circle of water on the top of her left lung, which he thought was from when she had the transplant. So that little piece of liquid has been with me all my life, and he didn't think it should be disturbed. Have you ever heard of this before?
You said transplant? What?
Yes. So Tracy, she's a patient of yours. She's almost 50 more. She had a colonic interposition at Birmingham Children's Hospital.
I mean, it'd be a little bit strange for a fluid collection to remain since childhood. So it's difficult to imagine what that is. I'll have to chat to Tracy about that. But I mean, as a general rule, a small fluid collection, which we do sometimes see them, usually there's something we can just ignore. We may not always know exactly what's caused it, but it doesn't sound like it's anything to worry about. But perhaps we need to talk about that when we next chat.
Okay, thank you. We're at 8, but perhaps if you don't mind, we'll carry on. We just have 5 questions left. Brilliant. Okay, so Claire's daughter has lung gap away, in hospital a year after birth, stomach pulled up to join under tension, many complications with her feeds, 18 months now, normal diet, life-threatening reflux and tracheomalacia, had a fundoplication at 7 months, reflux ongoing and silent aspiration, last scope and dilatation 2 years ago and biopsy. She's now 18, increased to 40 milligrams daily, plus Gaviscon to manage reflux. Used to take domperidone, but stopped as impacting her heart condition, has dysmetallidae. She's been very pale and tired and always cold. Might she need iron supplements, or could this be related to the magnesium that you mentioned earlier in the PPIs?
I mean, I doubt it because statistically very few people, but I mean, it'd be very easy to check magnesium levels. I mean, yeah, I mean, there's a lot to sort of talk about there, I guess. And I don't know whether she's seen someone who's really interested in these areas and who can really sort of work out what's what, because I think certainly if you came to me, I'd want to have a detailed discussion about all the symptoms, do an endoscopy, things like that, work out. I mean, it sounds like if the reflux is there, it sounds like the fundoplication isn't working. If it was a long gap, then you may have a short esophagus, which can, of course, exacerbate things. So I guess it's difficult to give really specific advice other than say to try and get referred to someone who has an interest in this area and can really try and get to grips with all your symptoms. And my experience is that we can't always make everything better. We sometimes can only help a little bit, but we can usually help to some degree with research. But I think you need to see someone who's to really unpick all of that.
Okay, thank you. Could TOFs be linked to POTS, especially in regard to palpitations?
I don't know. It's interesting. I have had a couple of patients in whom they've coexisted, but I don't think there's a direct link. I'm not aware of a direct link, no. So I think it was probably coincidental, the ones I saw.
Okay, thank you. This patient has recently had biopsies on 3 patches lumps in her esophagus. Professionals aren't concerned about the patches. However, does the change in the appearance of the esophagus mean that might be the start of Barrett's esophagus?
So possibly. I mean, it depends where in the esophagus. If it's Barrett's you can see really easily at the bottom of the esophagus, or if it's long, it can go up the esophagus. And the appearances with the naked eye are very, very obvious. And the biopsies don't necessarily always confirm Barrett's, but it almost invariably means there is Barrett's if it looks like it. But you can also get the characteristic appearance of those spots in the upper esophagus, and it's called gastric metaplasia. So what that effectively means is that you can be born sometimes with a little bit of stomach lining in the upper esophagus, and that I'm just wondering whether your question is referring to that. And that's something normally which has no risk like Barrett's because it's higher up. So I guess I'd need a bit more information. But I mean, the professionals who've seen it, even if they're not experts in patients who've had OA, they will be experts at looking at the esophagus. And if they've said there's nothing to worry about, I'm sure that's right.
Okay. Thank you. And we're almost just 2 more questions to go. I was advised that over time stretches are not as effective. It was described to me like an elastic band. After a while, it begins to tear and break down. What's the next step when stretches are no longer effective?
Well, okay. I mean, they usually are effective. I know what they're meaning. And a one-off stretch is not always effective, because the question is absolutely right that you stretch it and then it sort of goes back again, sometimes quickly, sometimes days, sometimes weeks, sometimes months. So you not infrequently have to repeat them. But usually we find the effect of each successive stretch is greater. So what happens is you stretch it, when you stretch a stricture, you're basically breaking the scar tissue of the stricture, and it then heals, but usually it heals slightly less narrow. So if you carry on dilating again, maybe a few weeks later, each time it heals less narrow. So eventually it stays wide open. So many people need more than one stretch, but most people only need 2 or 3 stretches. Very, very occasionally, people need regular stretches for years. And I have patients I sometimes see every 6 months and stretch it, and they come back 6 months later. I've had some patients who, my record is that I had one patient who needed over 200 stretches, starting weekly, then twice weekly, and every other week, then monthly, to the extent, and when I eventually finished doing it, it was every 9 months or something. So the question is correct. It does narrow down again, but it narrows down less each time. And eventually, in most people, in my experience, you can keep it open long term. And it's very, very rare that you have to operate to remove strictures. You can occasionally, but in most people, dilating it usually works eventually, but it might need several stretches.
Okay, thank you. Michael is telling us he's 73 years old, was born with a TOF. Sorry, he had surgery 73 years ago. He's always had swallowing problems. He had a scope in the middle of 2023 where a stricture was measured at 8 millimeters and thought, okay.
Yeah. And was it dilated? We don't know.
It sounds like it wasn't. Michael, maybe you can tell us if you're still on the call, if there was a dilation, because he said it measured 8 millimeters and thought, okay. So, compared to what you said earlier, that does seem very narrow.
8 millimeters isn't okay. 8 millimeters is pretty narrow. I mean, strictures, I've seen strictures which are down to 1 millimeter, but 8 millimeters is sort of a moderate stricture and absolutely will cause very significant symptoms of swallowing difficulties and absolutely should be. I mean, I don't know much about Michael and his stricture, but I would have thought it should absolutely be dilated and you could expect to improve things a lot.
So, Michael, if you're still on the call, tell us if you had a dilatation in the middle of 2023. And we'll just move on. The final question is someone who's trying to find a consultant at UCLH.
Yeah, good mate.
An adult.
So there are two consultants. There's Mr. Khaled Dawas, who's a great friend of mine, Khaled, and then surname is Dawas, Dawas. He is a fantastic surgeon. He was my trainee in Oxford, and he's a close friend of mine. And another fantastic surgeon down there at UCLH is Yasser Qureshi, and I'll spell his name Yasser, and then the surname is Qureshi, Qureshi. So those two are both brilliant. I'd recommend them very strongly.
Fantastic. Okay. Well, thank you very much, Mr. Maynard. I don't think we've heard anything else in relation to the dilatation from Michael, but it's now 8:10, and I think hopefully everyone found that as interesting and as informative as I did. And thank you so much for taking that wide range of questions, Mr. Maynard, as well. And that just leaves me to say thank you very much to everyone for coming. Thank you again, Mr. Maynard. Thank you, Kate, for posing those questions. And I hope you all have a really good evening.